So the topic of my presentation will be related to the uric acid that is one of the main interest in my last 10 years, and in particular the interaction between hyperuricemia and kidney dysfunction. Basically, we know everything about uric acid in terms of joint for its possibility to produce gout. But even more recently, we had a lot of information that the interaction with uric acid is not just through the inflammatory system of the gout pathogenesis, but it's also based on a strong interaction with many other target organ damage, in particular the cardiovascular system and the renal system. The interaction between the kidney and the uric acid are pretty complex because on one side, we have, of course, a large body of evidence that suggests that every decrease in the renal function is associated with an increase in the level of serum uric acid. But on the other side, the presence of elevated level of uric acid or hyperuricemia can induce the onset and progression of renal dysfunction, particularly in combination with the other risk factors. Actually, if you look at the traditional epidemiology as those that comes out from the NAIDS survey, you can see that in presence of hyperuricemia, there is an excess in the prevalence of renal dysfunction of the different level. And what is interesting from this picture is the fact that is always the presence of hyperuricemia, not simply gout, which is responsible for the decline in the renal function. Another interesting finding, always from the NAIDS group, is the observation that the relative risk of renal dysfunction can appear in this important population of patients for serum uric acid level, which are pretty below when compared to those which are suggested as possible dangerous. And from this point of view, I think the evidence on renal dysfunction are pretty much in agreement with those we have published in terms of the threshold level of hyperuricemia as a risk factor for cardiovascular disease. Of course, there are many studies that have tried to investigate the relationship between hyperuricemia and the progressive of chronic kidney disease, and all of them are moving exactly in the same direction. This is a meta-analysis published a couple of years ago and showing in the different setting and for the different, let's say, study design that increasing the level of serum uric acid is almost always associated with a significant increase in the rate of development of renal disease. And the same is true if you look at the different subgroup and the different subpopulation of patients included in the meta-analysis. You see from the forest plot that there are exactly no differences between the different subgroups, and the risk of renal dysfunction in presence of hyperuricemia is widely distributed among the different subpopulation that have been investigated. In particular, our URA group, who has investigated extensively the relationship between hyperuricemia and cardiovascular disease, have clearly demonstrated the reduction in renal function, which is associated with hyperuricemia, can also affect cardiovascular disease and total mortality. And you can see from these Kaplan-Meier curves that the lower is the level of GFR in presence of hyperuricemia, the higher is the probability that elevated serum uric acid are associated with the excess in cardiovascular disease and total mortalities, thereby again suggesting some strong interaction between hyperuricemia, renal dysfunction, and cardiovascular disease. Very recently, what we can call a reverse meta-analysis has been published, since has reported interesting results in terms of the observation that the rate of renal dysfunction and chronic kidney disease is reduced in patients showing a lower uric acid level. And as you can see, even from this point of view, the studies are all very consistent in the same direction, and the largest benefit in terms of prevention has been seen by comparing the patient with normal serum uric acid level with those in the fourth quartile. And I couldn't go through all my slides because it's too late, but I hope that you have listened to me And most of you, of course, knows very well the history. So that's exactly what I'm showing to you so far: the prevalence of renal dysfunction in presence of hyperuricemia, the level of uric acid, which is associated with an increase in the relative risk of cardiovascular of renal disease. The first meta-analysis showing an increase in the relative risk in the different studies going, all of them in the same direction, and the same is true in the different subpopulation of patients. So there are no doubts that increasing serum uric acid can contribute to the renal dysfunction. And the same is true in this reverse meta-analysis investigating the impact of lower serum uric acid. And again, you see the lower is the lowest is the level of serum uric acid, the lower is the rate of progression through chronic kidney disease. This is true, and that was the last slide I was showing to you. This is true in terms of overall rate of renal dysfunction or renal failure, and also in terms of progression toward the most severe stages of renal dysfunction. So this is probably one of the most important results, because it suggests the possibility that having lower uric acid level can in some way protect against the progression of renal disease. Which one could be the mechanism responsible for interaction between hyperuricemia and renal dysfunction? I think many of them have been investigated. First of all, the possibility of urate deposition at the tubular level can, of course, jeopardize the renal function and be responsible for the onset and progression of kidney disease. But I think most of the most interesting evidence are based on the possibility that hyperuricemia is involved in some kind of modulation of the balance at the level of the vascular balance at the level of the intraglomerular system, with some effect at the level of the afferent arterioli, due mainly to the oxidative stress, which is associated with the uric acid production. And from this point of view, there are interesting data suggested that some circulating and tissue substance, like the activating of the renin-angiotensin system or the availability of nitric oxide, can be responsible for some derangement in the intraglomerular circulation. And this could be responsible for the progression of renal dysfunction in this population of patients. I think needless to say that in addition, we have to remember that hyperuricemia is a factor which is responsible for the onset and the poor control of high blood pressure. And of course, the presence of high blood pressure level can contribute to the progression, onset and progression of the renal dysfunction. So what we can do from the treatment point of view, of course, we have a couple of interesting opportunities. The first one is, of course, the diet. We should try to reduce the amount of food that are increasing the circulating level of uric acid, but the diet should be integrated with urate-lowering drugs. And among the urate-lowering drug, I think most of the information have been provided for drug inhibiting the xanthine oxidase, the so-called xanthine oxidase inhibitors, and in particular allopurinol and febuxostat. A small Cochrane review has been published some years ago. It was showing that the use of xanthine oxidase inhibitors was able to improve the renal function in patients with chronic kidney disease. And this very small meta-analysis has been recently integrated by a larger one, which has been published in the last 3 years, and showing on a larger base of investigational studies that the treatment with urate-lowering drug was able to reduce not only the progression of the renal function toward the more severe degrees and the development of chronic renal failure, but also confirm a concomitant reduction in the rate of major cardiovascular events, which means that probably we have a common ground between the decline in renal function and the onset of cardiovascular disease. And the same is true if you look at some proxy of renal function. Again, the reduction and the use of urate-lowering drug was significantly increasing the level of eGFR and reducing the level of proteinuria. So some kind of overall effect in terms of renal protection. of course, beside these review of the available literature, we have some single studies that are supporting that the reduction of uric acid level butyrate lowering drugs can have protective effect on the renal function. The first most important is probably the FREED trial carried out in patients with hyperuricemia, but without renal dysfunction at the very beginning, at the baseline. And this trial was positive since demonstrated a reduction in the overall component of the primary endpoint. What is interesting is that most of the benefit was clearly supported by a reduction in the rate of renal impairment. The same was true for another trials carried out again in the Japanese population. The FEATHER trial, in this case, carried out in patients with the stage 3 CKD and aimed at investigating the possibility that the treatment with febuxostat was followed by a reduction in the renal dysfunction. Actually, the trial did not reach statistical significance in the overall population of patients. But if you look at the two main subpopulation of patients, those with more preserved or less preserved renal function, it's pretty clear that the benefit in terms of preservation of GFR and reduction and changes in serum creatinine was pretty more evident in response to febuxostat in the subpopulation of patients with milder renal dysfunction. That clearly suggests the possibility that if you would like to achieve some benefit, you have to start the treatment earlier as possible to protect the renal function. In terms of comparison between the two different xanthine oxidase inhibitors available on the market, we have this comprehensive meta-analysis between febuxostat and allopurinol that clearly suggested that in terms of changes of serum creatinine and GFR, there are no major differences, even whether the treatment with febuxostat was followed by a larger improvement in serum uric acid and a decrease in the renal excretion of albumin. And another study has been carried out again through a head-to-head comparison between allopurinol and febuxostat, in this case in patients with more severe renal dysfunction. And in this case, you would see there was a significant difference between the two treatment favoring the patient treated with febuxostat, even in terms of evolution of incidence of severe renal disease or in terms of progression toward the more severe renal dysfunction. That clearly suggests that probably the most selective inhibitor of the xanthine oxidase with less probability of negatively interacting with the kidney can give more advantages in terms of preservation and protection of the renal function. Of course, as it happened always in science, not all the studies are going in the same direction. And there are some evidence that are clearly not supporting a beneficial effect of urate lowering treatment in terms of protection of the kidney. And even in some cases, only for, let's say, pretty complex animal studies, someone suggests also that hyperuricemia without deposition of uric acid, it could be even protective in terms of progression of renal dysfunction through a favorable interaction with the mechanism responsible for the progression of fibrosis. This evidence is clearly supported by the publication of a couple of trials in the New England Journal and carried out in terms of comparison between urate lowering treatment and placebo. One is the CKD FIX study, which has been carried out in patients with CKD. And in this case, you see the treatment with allopurinol was not associated with a significant improvement in the changes in GFR in this important population of patients, even whether the number of patients was pretty small and the study was interrupted ahead of the end of the enrollment. Another study is the PEARL study, which has been carried out in patients with treated with allopurinol and patients with type 1 diabetes. You will see a significant reduction in serum urate, and again, just a non-significant trend for a lesser decline of GFR. But in this case, I think The problem is the population, because in this population of patients, the progression of renal dysfunction is certainly based on the mechanisms which are underlying the diabetic renal disease. I do not believe that changes in serum urate can be largely involved in the progression of renal dysfunction. So basically, why we have this difference? Can we explain rationally the difference between some two different kinds of studies? I think the two main problems are, on one side, a more correct identification of the patient, and I know that it is true for every trials involving the urate lowering treatment, and the other one is the selection of the studies that we are going to take into consideration. Because in terms of identification of the patient, we know that within the population of patients with hyperuricemia, we have probably two different subpopulation of subjects in terms of overexcretion, under-excretion of overproduction. Both these conditions can be responsible for renal disease, but probably only in this population of patients, the patient in which there is an overproduction, we have to expect some benefit in terms of urate lowering treatment, in particular by using xanthine oxidase inhibitor. The problem of the selection of the study has been investigated by Rick Johnson, and with a paper with many friends that I was involved in, showing that probably if you look at the overall number of studies, we have some of them which are interpretable and some of them which are not interpretable in terms of changes in renal function. And in particular, the difference between the two different studies is the fact that in about 50% of the trial that have been used to define this topic, there were no changes whatsoever in GFR in the placebo group. So I think it's very difficult to find out the impact of a drug if you don't have any, let's say, progressive decline in the renal function. These are the non-interpretable studies. You see, none of them have been significant. On the other side, we have some interpretable studies in which the main characteristic was some decline of GFR or serum creatinine, or changes in serum creatinine in the placebo group. And all these studies have shown some benefits. So I think that basically when we discuss about the impact of urate lowering treatment in terms of renal protection, maybe we should try to investigate, we should try to identify the right patient, because otherwise probably we made a lot of mess. Just before closing my review, what we can do today, do we have any option beyond urate lowering treatment to protect the kidney in patients with hyperuricemia? Probably yes. One possibility is the treatment with losartan. Everybody of you is aware that losartan has some uricosuric effect, which is based on its interaction with the URAT1 at the renal tubular level. And we have some evidence from the live trial that the reduction of uric acid is contributed to the reduction in cardiovascular disease. But you have even more interesting information from the renal trial, which is showing that the reduction in losartan, in the level of uric acid that we can achieve with losartan in this trial, is associated with the lesser decline of renal function and the lower proportion of patients doubling serum creatinine or evolving toward end-stage renal disease. But I think the most important class of drugs on this point of view are probably the SGLT2 inhibitors, which seems to do almost everything in the cardiovascular and renal and cardiometabolic diseases. What is important, and among the mechanisms of benefit of SGLT2 inhibitors, there is also the significant reduction in serum urate level. This has been reviewed by this large meta-analysis of 2017, and showing that for almost all the molecules belonging to this class, there is a significant reduction. There is a possibility of a significant reduction in the plasma level of uric acid. It could play some role in terms of cardiovascular protection and in renal protection as well. And this is true also in current daily practice. effects in real life. This is a very recent published paper showing that empagliflozin in real life is able to significantly reduce the level of uric acid. And it's interesting that for all these studies in which some reduction in serum uric acid has been demonstrated in the trial and in many cases published as a separate paper, there is a significant improvement, a significant protection in renal function and an interaction with the progression of the renal disease. And there is a remarkable possibility that this a favorable renal effect of these very fantastic classes of drugs, there is some contribution strictly related to the reduction in the plasma level of serum urate, which is typical of this drug. So finally, these are my conclusions, that is the serum uric acid has a close interaction with the kidney. Hyperuricemia is associated with a decline in renal function in patients with and without chronic kidney disease. Urate lowering drugs can have a protective effect on renal function in patients with different degrees of renal involvement. The evidence of benefit is influenced by drug profile, patient characteristics, and trial design. And finally, drugs reducing serum uric level, but not primarily addressing hyperuricemia, can contribute to the renal protection. Again, I would like to thank Vasilios for this invitation. It was a great honor to have the opportunity to spend some time with you.